Hi everyone, my name's Gracia. I'm a physiotherapist here at Kobodi Wellness Studio with a special interest in pelvic health, and today we're going to demystify bladder and bowel issues, talk about causes, and most importantly, empower you with some treatment options. So what are we going to cover today? So today we're going to talk about types and causes of incontinence, impact on quality of life, physiotherapy management, and nutrition strategies for continence. So what is incontinence? Incontinence is the involuntary loss of bladder or bowel control, and it's more common than people think and can affect anyone regardless of their age or gender. So there's a few different types of incontinence. Stress incontinence being leakage that someone would experience with coughing, sneezing, or lifting. There's also urge incontinence, which is a sudden strong urge to wee or poo followed by some leakage. There's also mixed incontinence, which is a combination of both. There's also overflow, functional, and fecal incontinence, which is less common, but is still definitely treatable. So a little bit of a myth buster. Incontinence is not something that is normal and should just be accepted. It's a health condition, and there's definitely help and support to manage it. So what are some of the causes? So in women or with people with female pelvic organs, these are some of the causes: pregnancy, childbirth, especially vaginal births. We know that with pregnancy, the increased load on the abdominals can put a bit of a strain on the pelvic floor muscles. We'll go into a little bit deeper about the anatomy of the pelvic floor muscles in a short bit, but essentially the extra weight puts a bit more pressure. Hormonal changes during menopause can also impact the way the pelvic floor behaves. Pelvic organ prolapse, surgery such as a hysterectomy, and in men or in people with male pelvic organs, prostate surgery can definitely affect the pelvic floor, weak pelvic floor muscles, and certain neurological conditions. And in both genders, these are some common causes: so obesity, chronic cough or constipation, high impact sports, as well as poor bladder or bowel habits. Some examples of poor bladder or bowel habits would be if you tend to sort of hold your wees for longer periods than you should, or you ignore the urge to go. These are some issues that can cause incontinence down the track. So let's go into a little bit more about the anatomy of the pelvic floor. To understand why physiotherapy works so well for incontinence, it helps to have a basic understanding of the pelvic region, specifically how the pelvic floor works in harmony with the muscles around it. So what is the pelvic floor? The pelvic floor is a group of muscles and connective tissues that form a hammock or a sling at the base of the pelvis. So you can see on the picture there, this is basically a picture of your pelvis looking down. So you can see at the bottom there, it's the sling of the pelvic floor. It acts like a hammock, and your intestinal organs and other reproductive organs sit on top of that hammock. It supports the key organs: bladder, bowel, uterus, or prostate, depending on sex. And you could think of it as your body's internal support system for core stability and continence control. So where is it located? So this is a different picture of your pelvic floor. It's actually looking from underneath. The bones on either side is your pelvic bones. So it stretches from the pubic bone at the front of your pelvis, and it extends all the way back to the tailbone and between the sitting bones side to side. So in terms of the muscles have generally two different type of fibers. We have the slow twitch and the fast twitch. The slow twitch being the endurance fibers, and the fast twitch meaning the quick reaction muscle fibers. And both of these are important because we want the slow twitch endurance fibers to maintain a longer contraction, whereas we want the fast twitch muscle fibers to respond to sudden urges, like when you sneeze or when you laugh. And this is also, some people might have heard of it, is like practicing the knack, and that's when you basically do a fast or a quick pelvic floor contraction to help hold sudden pressure. And this is the connection to the pelvic and core muscles. The pelvic floor muscle doesn't work alone. It's part of a team called the core canister, which includes the diaphragm at the top, the deep abdominal muscles at the front, the multifidus muscles at the back, and the pelvic floor muscles at the bottom. And all these muscles have to work in unison in order to have an appropriate pelvic floor contraction. There's also surrounding muscles that interact with the pelvic floor, such as the gluteus maximus and medius, which is around your pelvic area, and it assists with pelvic alignment and hip stability. You also have your hip rotators in the hips, and as well as the adductors, which is in the inner thigh, which also influence pelvic stability. We do know that tight or weak hip and glute muscles can place excess load on the pelvic floor, or limit the ability of the pelvic floor to activate efficiently. So why does this matter for incontinence? If the pelvic floor is weak, overactive, or not coordinating well with nearby muscles, you can experience leakage of urine or stool, pelvic pressure or heaviness, core instability, or back pain. And that's why pelvic floor physiotherapy often includes hip and glute strengthening or release work, because restoring balance in the entire region can make a big difference to improve continence. And how can physiotherapy help? So generally, treatment includes pelvic floor muscle retraining, and that involves learning how to activate the right muscles in your pelvic floor and making sure that contraction is appropriate. If you think about it, it's like holding in a fart or holding in a wee, and you can think of it like a plane taking off. So back passage to front passage taking off in unison. We teach this in clinic using the real-time ultrasound. So it's a non-invasive ultrasound. We basically look through just on top of your, just below your stomach. We can see your bladder through the ultrasound, and we can see from there how the pelvic floor contracts. So if you can see the picture in the slide there, it's basically, you can see a black box, and it's the white base at the bottom of the box is your pelvic floor muscle. And in real time, we can see how you respond to cues and how the pelvic floor muscle contracts. We also do customized programs, exercise programs, depending on underactive or overactive muscles. We can also teach some bladder retraining, so techniques to delay or manage the urge to go, and scheduled voiding and urge suppression strategies. Other education include lifestyle modification, toileting posture and habit. Toileting posture is a big one as well, to make sure that your pelvis is in the right position to be able to void appropriately. The treatments we offer is real-time ultrasound, and generally with manual therapy, we do look at the pelvic area as a whole, which includes the glute muscles. And as I mentioned last time, sometimes when the glute muscles are tight or weak, there might be some manual therapy that's involved in order to release those muscles. Now, before I hand over to Aisha, I thought we can practice some pelvic floor activation. So if you can see the picture in the slide there, you can see the pelvic floor is that sling underneath. And like I said last time, see if you can practice a lift. So basically you're going to lift up, imagine you're holding in a fart or a wee, and we're just going to hold that for 5 seconds. So 1, 2, 3, 4, 5, and as you relax, you should feel your pelvic floor relaxing. If you don't feel it relaxing, it means that you might have lost a contraction somewhere along the line. Now this time we're going to do 10 quick pulses. So I'll get you to hold the fart again really quickly and release. Hold, release, hold, release. Keep going. 4, 5, 6, 7, 8, 9, 10. Great work. So basically during those contractions, you want to be able to feel a lift or feel a descent. If you're struggling with any of the cues, or struggling to feel what a contraction is supposed to feel like, reach out to your nearest physio. Anyone with real-time ultrasound essentially would be able to have a look at how you're contracting those muscles. So now I'm going to hand over to Aisha, who will cover the dietetic management of continence.
Thank you, Gracia. That exercise was quite challenging. I won't lie. Now, just to cover some of the dietetic information and supports that there are for both fecal and bladder incontinence, I just want to take a minute as well to really acknowledge that there is quite a big impact on quality of life. And that's something, I suppose, if it's you or yourself or a loved one that is managing or dealing with these issues right now, some of the really common things that you might be feeling or they might be feeling is, a bit of shame, a loss of independence, might be avoiding, exercise or regular activities. There might be increased laundry, like financial implications, having to stock up on potential incontinence products. And then if you're caring for someone, obviously we want to take into consideration like the caregiver burden. It's often quite high, particularly if you are caring for someone like an older adult or someone with a neurological condition or cognitive decline. So that's something that I suppose when we work with clients that are struggling with these issues, whether it's themselves or a loved one, we really do try and take these elements into consideration. So I did want to take a moment to note that as well. Now, Gracia did really explain the kind of different types of continence, but just to revisit and expand, there are several kind of distinct types. And just to go into a little bit more detail, that's the stress incontinence might be leakage during exertion. That might be from like coughing or sneezing or even exercise. Urge incontinence, or maybe like an overactive bladder, would be the sudden urge to urinate with little to no warning. Overflow incontinence, this might be that the bladder is not emptying fully, resulting in frequent leakage. Or functional incontinence, which is either connected to physical or cognitive impairments, preventing timely toileting. And then when we look at different types of fecal incontinence, there might be urge, so a sudden need to defecate and an inability to hold it. Passive fecal incontinence, which is some unnoticed leakage. This is quite common in nerve damage or poor people, I suppose, with conditions and poor sphincter control. Soiling, and that's often caused by constipation or incomplete emptying. And sometimes there may be an overlap. And we might call this like dual incontinence. And this is quite common in older adults with people with neurological conditions. And we often see it quite a lot in institutional, like aged care settings, linked to functional decline. So I think what's important as well is to acknowledge the link between constipation and fecal incontinence, or even just bladder incontinence as well. There is a bit of an overlap. So chronic constipation, I suppose what can happen is it can stretch the rectum and reduce sensation, cause overflow of fecal incontinence. And in older adults, fecal impaction can lead to bladder pressure. So again, there's that overlap between constipation and potentially bladder incontinence. And then functional limitations might worsen, toileting access if someone has like very severe arthritis. This can impact their functional ability as well. Constipation is also, both a cause of and consequence, I suppose, of incontinence. So it can go both ways. When we look at some of the causes and contributing factors, some of them we've noted already, but some can be age-related changes, muscle weakening, menopause, enlarged prostate. Neurological conditions might be stroke, MS, spinal injuries, obstetric trauma, pelvic floor damage, like we've touched on so far. Some certain medications, laxative opioids, and some others there as well. Diet and fluid intake do have a big influence. Low fiber or fluid could be a contributing factor, as well as, I guess, maybe a high intake of bladder irritants. Some infections, even if short-term, like UTIs, dehydration, or other illnesses. Obesity, so like increased abdominal pressure, can weaken the pelvic floor, and we can talk a little bit more about that as well. And then some lifestyle things like excessive caffeine or alcohol or sedentary habits. And these, might not affect everyone in the same way, but they're just some things that may contribute or worsen symptoms. I think what's important to note is, from like a safety perspective, I suppose, is what we need to look at if there's new onset of incontinence and maybe some red flags and what we might need to do. So new or quite sudden symptoms might be indicative of an infection, something neurological, or a medication side effect. It's very important to, seek support from a GP. It might be that an assessment might be required, like are we looking at temporary versus chronic incontinence, urinary or fecal, or functional or structural. So understanding that is important to, I suppose, getting the right treatment plan in place as well. When we look at specific nutrition and hydration strategies for both bladder and fecal incontinence, one of the first things we would want to consider and look at is fiber. And I will say a lot of this does differ on perhaps the reason or underlying cause of the incontinence, but these are just some things that might be relevant. So fiber, focusing on soluble fiber, so things like oats, psyllium, bananas. These types of fibers often help bulk and soften stool, and it's helpful for both constipation and diarrhea. On the other side of that, we might just want to be mindful of insoluble fiber. So types of bran cereals, the skins of fruit and veg, these kind of promote bowel movement, so they may worsen symptoms in some. These are kind of 2 points why it's quite important to be working with a dietitian, depending on, I guess, the underlying cause, because that manipulation and gradual, I guess, treatment plan around fiber would be quite important. For the general population, it's 25 to 30 grams a day, but we do introduce that slowly, and we need to ensure we're really properly hydrated. Too much fiber and not enough fluid can just really increase that constipation risk or severity as well. When we look at hydration, ideally we want to be aiming for at least 1.5 to 2 liters a day, unless it's medically restricted. Dehydration just results in kind of concentrated urine, bladder irritation, which can worsen symptoms and, I guess, just discomfort overall. A low fluid intake can also result in harder stools, and this might worsen constipation and overflow fecal incontinence as well. Depending on, I guess, what works for some people, we might need to be encouraging regular sips rather than having large volumes in one go, so trying to spread out that hydration across the day. Drinking water is recommended even if you suffer from incontinence, either bladder or fecal. It helps keep the bladder clean, reduces the risk of infection and irritation, and ultimately hydration is just super important across the board. It might just be the way we consume it and the steps and habits we introduce around it that we might need to manage. I would say try and avoid drinking water 2 to 3 hours before going to bed, potentially, would be one of the things I would first suggest. Again, especially if a lot of older adults may start to experience either incontinence, but more bladder incontinence or urgency kind of overnight. We might look at controlling the amount of liquid overall, particularly in those older patients, just as the sensation of thirst actually does decrease as you get older. So we just need to, again, it's very personalized, and each person will be quite different. I can't stress enough, though, how important adequate, I guess, liquid and fluids are, and drinking too much or too little can be harmful. So it is very important to kind of ensure that you're working with someone who can specify and personalize it to your needs as well. In terms of foods to limit, so we would call these maybe like bladder irritants. They can relate to I guess, bowel movements as well. So caffeine, decaffeinated drinks, though they contain less caffeine, they're not usually recommended either. Alcohol is something to limit. It ultimately just dehydrates you, makes you need to go to the bathroom more often. It also interferes with some brain signals that tell your bladder when to release urine. Artificial sweeteners can be quite irritating, particularly for the bowel. Spicy or acidic foods, carbonated drinks, and that one's particularly on the bowels again. There is some research that has shown that a low FODMAP diet might support people experiencing fecal incontinence, mostly related to those symptoms around loose bowels and urgency, though it's not common and may more strongly be related to IBS, which is a separate condition. So I just do want to note that IBS is separate. So we would, again, want to understand if the symptoms are, like, say, if it's fecal incontinence and urgency and loose bowels, is that a result of IBS or is it a result of an underlying a different condition. So I think that's where that would come into play. We always would want to consider, whether here at Kobodi or with your GP, we should be considering the whole patient, their symptoms, history, any co-occurring conditions or other potential causes or contributing factors. And then to expand, just some foods that may trigger bowel urgency. Some are similar, like say those sugar alcohols, like I said, in terms of artificial sweeteners, they fall into that same category. Fatty or fried foods, highly processed foods, and again, just more around that fatty, fried foods, and then also spicy foods. And I think that's a pretty common one for a lot of people, but can be worse in those experiencing sort of bowel urgency. I do want to touch on weight management. Research has shown that excess weight can increase intra-abdominal pressure and worsens that stress and urge of incontinence. Weight loss of even just 5 to 10% can significantly reduce those symptoms. Regular physical activity is obviously super important, particularly when it's pelvic floor friendly, working with your physio, and a balanced fiber-rich diet, but again, very personalized. I do just want to note that please avoid crash dieting, avoid skipping meals. This can also disrupt bowel patterns, blood sugar balance, and all of that. We would always want to work with you to, generate a plan that is going to support your goals, your overall health. It's weight management's not as simple as I think we are led to believe, and a very personalized approach is often needed to tailor it to your lifestyle, what works for you and what's important to you as well. Now, some of the foods that might specifically support urinary incontinence. So it's really important to incorporate food into the diet that stimulates and regenerates the cells of the genital mucosa and kidneys, as well as the bladder and the muscle tissue. So really we want to focus on foods that contain vitamins, minerals, proteins, and nutrients contribute to overall really just maintaining and supporting the immune system. And this is what helps that regeneration of the cells. And this helps decrease risk of infection, restores tissues, and ultimately prevents the weakening of the pelvic floor. So some of those foods might be, and it's not limited to this list, but blueberries, green peas, lentils, avocado, radish, nuts, fish, milk, yogurts, and eggs. I would say if you just want two most important foods or like key foods to start with green peas and radishes. Green peas are one of the most recommended foods in a diet for urinary incontinence due to the amount of vitamin A they have. It helps with strengthening of the kidney and bladder tissues. And they're super easy to get a hold of, very easy to cook, add into things, whether they're frozen or in a can, it really doesn't matter. And then radishes are very high in vitamin C, so have a very strong antiseptic benefit that speeds up the recovery of, say, if it was a UTI, and that's what's causing that incontinence or urgency. It also does help the vitamin C, that's not just in radishes, but vitamin C, it helps with urine control, relieves drips during the first phase of incontinence as well. And then just to expand on a little bit of this, like specific vitamins. So this very much overlaps with, the foods that are high in these vitamins, and then the vitamins to look for, whichever way you want to approach it. But evidence shows that vitamin C, E, B6, and magnesium are very beneficial when consumed in adequate amounts. This might be, like I said, the vitamin C could be like, instead of radishes, it might be citrus fruits, orange, strawberries. Vitamin E, you could use some olive oil, avocado, nuts, seeds. B6 and magnesium, meat, fish, green vegetables, coriander, mint, chives, pumpkin seeds, or sunflower seeds. I think we really underuse our herbs and spices, and I think that they provide so many benefits. So include more of those. But honestly, what you'll notice from that list is that really starts to incorporate a balanced, very nutrient-rich diet. So we can definitely sort of simplify it and tailor it to you as well. And it may depend on your symptoms and the underlying causes, and we would always take that into consideration as well. Then, if we look at like what are some practical tips, where do we start? How do we support not only like whether it's ourselves, but how do we support loved ones? I would say small, consistent changes. They really do add up. It doesn't have to be all these sort of changes and big additions overnight. The gradual small things really do add up over time. Drastic changes also feel very overwhelming, particularly when someone might already be managing pretty distressing symptoms. So focusing on realistic and achievable steps, like might just be increasing the water intake or gradually adding fiber or focusing on adding green peas. Like it might be that's one goal for 1 week, and like what can we work towards adding next week or the week after? Progress certainly isn't linear, and even small improvements, like they really can make a meaningful difference. Seek support from GPs, pelvic floor physios, and continence nurses if you have access. Incontinence rarely exists in isolation, whether that's fecal or bladder. So don't be scared to reach out to the professionals as part of you or your loved one's sort of support system. Something I use with patients is to maybe use a bladder and bowel diary to track patterns and triggers. So start connecting some dots. This can not only help us uncover some of those patterns with these symptoms, what might be related to diet and toileting habits, but it's very much a gentle exploration tool rather than a judgment, not at all a judgment. We're looking at it as a tool to link patterns or, create some sort of awareness. And I think framing it in that way to understand your body better may increase, someone's sense of feeling in control, and awareness of bodily sensations. So kind of reinforcing that, I guess, giving someone back some confidence that they may have felt they've lost as well. Supporting behavioral strategies, because it's not just about, I suppose, diet or lifestyle. Very much behavioral tips are a big part of it, and that might be regular toileting, so timed voiding or promoting it, and not avoiding, say, going to the toilet, ignoring bladder urgency or anything like that. Proper posture during bowel movements. Sometimes feet on a stool could help if it's you're struggling with constipation or kind of straining, and then pelvic floor muscle training, like Gracia touched on as well. These approaches can really help build control and confidence, and especially when combined with some positive reinforcement and reassurance. Setbacks are part of the process, but that it is very normal. Incontinence is common, it's manageable and treatable, at least in the way that we can certainly improve quality of life and support symptoms. Normalize, either your or your loved one's experience. Let them know they're not alone. It affects people of all ages and backgrounds, and it's certainly not something that someone should be ashamed or embarrassed about. And I think that's sometimes the barrier to people seeking support or, even just healthcare for it. So reassure them that help is available. Their dignity, privacy, and goals are always at the center of the care, particularly here. It's something we would always promote. So if you would like to, work on some of these things, improve your pelvic floor muscles, just your overall bowel and bladder health, or of someone who might be struggling, please feel free to reach out to the clinic, give us a call, send us an email. And yes, thank you for joining.